But it's great that you guys are all here because it is one of the more complicated lectures, so I'm glad you came. Acute kidney injury is a fun topic because it's a chance for pharmacists to play detective. Somebody's going to come in with renal failure, and physicians often say, "Pharmacy, I have no idea why this patient's in renal failure. Do you think there's a drug that's contributing to this?" You guys get to look at certain clues and try and figure out what the cause of the acute kidney injury might be. So it's kind of a fun clinical game that comes up quite often when you're around in the hospital. Here are the objectives for today. I feel like they're getting longer and longer, so don't look at them right now. Look at them when you study, and I will write my exam questions off of these objectives. Basically, the goals for today are: one, I need to spend the first half of class talking about what acute kidney injury is. So we'll have a lot of definitions and categories of acute kidney injury. And then with the second half of class, we'll talk about drug-induced kidney injury, which I think is much more fun than maybe these basic definitions, because we get to talk about what drugs hurt the kidney, in what way, and what can we do to prevent that kind of kidney injury from occurring. But we've got to start out with some definitions so that we're all on the same page. Acute kidney injury is abbreviated AKI. So if you see that abbreviation, that's what that is. And it's really an abrupt decline as opposed to a chronic decline in renal function, where you see the kidney start to lose its ability to filter waste products and to maintain fluid and electrolyte balances. And I have to tell you that this term, acute kidney injury, is only a couple years old. It used to be called acute renal failure, or ARF. And they recently changed this definition because, one, the kidney associations don't like the word renal because they think that a non-lay person wouldn't know, or a layperson would not know what renal meant, so they like to put kidney in the term. And they also thought that acute renal failure sounded like an all or nothing type of thing, like either you had great kidneys or they had failed. Acute kidney injury is a term where you could have mild acute kidney injury, you could have moderate, you could have severe. So that's why they switched. However, you'll see in my slides, some of my figures are more than a couple years old. So if it says ARF, or acute renal failure, just know that I'm talking about AKI. I updated what I could, but some of the nice figures still say ARF. Now, there are a million ways to classify AKI, so I just picked two of them for you, two very common classification schemes. One has to do with creatinine, and one has to do with urine output. So for creatinine, acute kidney injury is an increase in serum creatinine of greater than 0.5 if your baseline serum creatinine is less than 3, and greater than 1 if your baseline serum creatinine is greater than 3. Now, the reason they had to make that distinction is that if your baseline creatinine is already 3, that means you have pretty poor kidneys to start with, and poor kidneys aren't so good at tightly regulating your serum creatinine level. So it might change a little bit from day to day if your serum creatinine is above 3. So that's why we look for a bigger jump if you have poor kidneys to start out with. Does that make sense? Okay, great. The second definition of acute kidney injury comes from urine output, and these definitions will be important to know for the exam and for life. The first one is anuria, which means that a patient is making less than 50 milliliters of urine a day. An in Greek or Latin means no, and urea means urine. So essentially these patients are making no urine. 15 ml, that's nothing. Oliguria means that you're making 50 to 500 milliliters of urine a day. Oligos in Greek means some, so it's saying that you make some urine. Non-oliguric is just as it sounds. It means you're making more than just some urine. You're making greater than 500 milliliters per day. You might still have acute kidney injury, but you're still able to produce a large amount of urine. The last couple of definitions that are important to know would be the term azotemia. Azotemia refers to the accumulation of nitrogenous waste. By nitrogenous waste, I mean elevated serum creatinines and elevated BUNs. Uremia is a clinical syndrome that develops when you have azotemia. So, for example, if a patient goes into acute kidney injury, they might not know that they have poor kidneys until they start feeling nauseous or throwing up. If the waste products build up high enough, they can cross the blood-brain barrier and cause mental status changes as well. So uremia is not just the elevated lab values telling you that you have high waste products in the blood. It's a situation where the patient is starting to be affected by those high levels. So now that we have the definitions out of the way, I have to harp on what a sad thing it is to get acute kidney injury because it is associated with increased morbidity and mortality. So to illustrate this point, we have a landmark study that was published, I believe, in 2002 by the Picard researchers. This program for the improvement of acute renal dysfunction is what Picard stands for. And in this study, they looked at 4 ICUs in 4 different academic medical centers. I think it was like Cleveland Clinic, UCSF, and a couple others. And they looked at outcomes based on whether a patient was non-oliguric, meaning they might have had some AKI but they were still producing urine, versus if they were oliguric, which means they're making some urine, but it was significantly reduced. And anuric patients fell in this category as well. As you can see, if you have acute kidney injury that's bad enough that you start making less urine than usual, you have a higher hospital mortality, you have a higher chance of dying in the ICU, and the 28-day mortality is worse, and you have a much lower chance of having your renal function recover. So we really want to try and prevent patients from developing acute kidney injury, especially acute kidney injury where your urine output is reduced, because the outcomes are not good. The last figure I have to illustrate how poor these outcomes are came from a study published around the same time as the Picard study. On the x-axis here, we have different types of patients that were admitted to the ICU. We have patients that didn't have any renal failure, and so of course didn't require hemodialysis. We had patients that did go into AKI or acute renal failure, but still had good urine output, so didn't need hemodialysis. We had patients with chronic kidney injury, ESRD is end-stage renal disease, so they were on dialysis, but they always needed dialysis. And now we have the group that we really want to look at. These are patients with AKI that was so bad that they stopped making urine and they needed hemodialysis. Look at the mortality rate for that group. I would say 55% of patients with AKI that required hemodialysis passed away. That's terrible. That's more than every other patient passed away if they developed that. So I used to give this lecture at the University of Michigan, and about a few months after I gave the lecture, a student pulled me aside in the hallway and said that she had a hereditary condition that predisposed her to developing rhabdomyolysis more frequently than other patients. And recently, she had woken up in the ICU after having had a big bout of rhabdomyolysis. And she said the first thing that she thought about as she opened her eyes and looked around her was, I've got to pee, I've got to pee, I've got to pee. Because she did not want to be in that group that had reduced urine output because she knew the mortality rate was so high. Now, I would say that she was young, and hopefully that wouldn't have been such a high mortality rate, but it was interesting that that's what passed through her mind. And she was doing great after that, but she knew that she really needed to pee because she did not want to be oliguric or anuric. All right. Now we can talk about the different types of acute kidney injury that occur. There's 3 different types. There's pre-renal acute kidney injury, intrinsic, and post-renal. Pre-renal refers to decreases in blood flow to the kidneys. which can result in some injury. Intrinsic acute kidney injury refers to actual problems that occur in the kidney. So if something happens to the glomerulus, the tubules, etc. Post-renal refers to something that's affected the kidney after kind of the kidney organ itself. And what I mean by that is obstructions of your ureters, obstructions of your bladder. Those are post-renal types of acute kidney injury. And we're going to go through each one in a little bit more depth. So let's start out with pre-renal acute kidney injury, because that's by far the most common type that you're going to see. As I mentioned, pre-renal AKI occurs when something decreases blood flow to the kidneys. So the cause happens before the kidneys. It's this decreased blood flow. There's actually no damage to the kidneys with pre-renal AKI. It's just that your blood flow is slowed down, so your glomerular filtration rate has to slow down because less blood is being delivered to the kidneys. Now, of course, anytime you cut off blood flow for too long, there will be damage. That will fit into the intrinsic AKI. So let's talk about what types of patients are going to have decreased blood flow to their kidneys. In the hospital, it's patients who have had major surgeries, because if you lose a lot of blood, then that's less blood volume that you have to deliver to your kidneys. Septic shock can also decrease blood flow to the kidneys because patients with septic shock have very low blood pressures. And your body knows to shunt blood up towards your brain and keep your brain function going over keeping your kidneys going. Finally, patients with decreased cardiac output. So if you have a CHF patient or someone who just had an acute MI, if their heart is not working well to pump blood to the kidneys, you'll see a decrease in GFR that way. In the community, pre-renal AKI is much more straightforward. Usually it's dehydration due to vomiting or diarrhea. Because if you are dehydrated, that means you have less blood volume to work with, and less is going to get to your kidneys. Finally, there is also drug-induced pre-renal acute kidney injury, and we'll talk about that a lot in the second half of class. But know that diuretics, NSAIDs, and ACE inhibitors are our main culprits for pre-renal AKI. One last point about pre-renal AKI. If you guys can understand this point, pre-renal AKI will be a lot less mysterious to you guys. The patients who develop pre-renal AKI are those that are intravascularly depleted. What I mean by that is the people that have less blood volume in their vessels that end up delivering less blood to their kidneys. So for example, patients with CHF have reduced cardiac output, and so they end up having decreased renal blood flow. Patients who have low proteins in their blood, remember that fluid likes to travel from areas of low concentration to high concentration? If you have low levels of albumin in your blood, fluid is going to leave your vessels in search of other places. And those people have decreased intravascular volume. They may look really fluid overloaded. For example, an ascites patient has a lot of fluid on board, but that fluid isn't in their blood vessels. So they actually act dehydrated even though they have so much fluid on board. Have you guys heard the term third spacing before? No? Okay, well I'll explain it right now because it'll come up again, I swear, in therapeutics. The first space is supposed to be your blood vessels. I tried to draw this here. The second space is your cells. And the third space is in between your cells. So when water leaves your blood vessels and travels in between your cells, that's called third spacing. And we usually think of anyone with edema as having third spacing. So swollen ankles, that's third spacing. Having ascites is third spacing. There's less volume in their blood vessels, even though there's lots of fluid on their body. So these are the people that are going to get your pre-renal acute kidney injury. And we'll revisit that about drug-induced AKI as well. Does that make sense? It's anyone that has low blood flow to the kidney for various reasons. All right, let's move on to intrinsic AKI real quick. This is the second most common type of AKI that you'll see. And there's a whole variety of different ways that your kidney can be harmed. For example, if anything harms the blood vessels to your kidney, that would count as intrinsic. So patients who develop a vasculitis, like an inflammation of the vessels, can be affected. Particularly if there's an inflammation of your glomerular capillaries, that would be a problem. We see glomerular damage occur in advanced stages of lupus, and also with an autoimmune condition that causes glomerulonephritis, which is just like it sounds. It's the itis, inflammation of the glomerulus. Your tubules can also be harmed with acute kidney injury. Tubules do a lot of active transport, and they have a lot of enzymatic processes going on, and so they need a lot of oxygen. Anything that cuts off oxygen to the kidney is going to hurt the tubules first. In fact, we almost think of the kidney as what's called a canary organ. Do you remember when miners go into a mine, they used to bring a canary along with them, and if the canary died, they knew they needed to get out of the mine quick because the canary was more sensitive than they were. In your body, if something's going on that depletes your oxygen levels, your tubules are the first part of your body to poop out from a lack of oxygen. And so they're almost the canary organ for the body. If somebody goes into kidney injury, you can start looking for something else going wrong because the kidney's tubules are that sensitive. Finally, you can also develop an inflammation of the interstitium. The interstitium is that tissue that surrounds the glomerulus and the tubules that helps maintain the tonicity of the kidney. That tissue can get inflamed, and that's called interstitial nephritis. Drugs can cause that inflammation reaction, and actually strep can cause that reaction, which is why it's so important to treat strep quickly. All right, the last one to think about is post-renal AKI. And again, that refers to a lot of obstructions of either the ureters or the bladder. Even if the tubules get obstructed, we probably call that a post-renal AKI. The most common by far reason for post-renal AKI happens in older men who get an enlarged prostate. If that prostate gets large enough, it's going to block the bladder outlet so that they can't pee, and all that increased pressure will cause acute kidney injury on the kidneys, cause injury to the kidneys. The ureters can also get blocked. This happens with cervical cancer. If you grow a tumor large enough, it will start to block the ureters, causing increased pressure on the kidneys. And retroperitoneal fibrosis is this somewhat rare condition where you grow extra tissue retroperitoneally. So like behind your stomach, there's an increased amount of connective tissue. And if you grow this, it's usually benign, but some people it ends up blocking their ureters, causing AKI that way. Finally, definitely kind of the most coolest thing to think about as a pharmacist is that drug crystals can block tubules and ureters. We think of a couple of sulfa drugs that can crystallize in your tubules, as well as a cyclovir. Tumor lysis syndrome, you guys haven't had oncology yet, right? Certain cancers, when treated with chemotherapy, can cause what's known as tumor lysis syndrome. That just means that as the tumors crack open, they release all of their contents into the blood, and tumor cells are full of uric acid. So uric acid crystals can end up clogging your tubules if you have tumor lysis syndrome. Finally, calcium oxalate. You know where that might occur? It's just a fancy description of what's in kidney stones. So if someone gets kidney stones a lot, they might get acute kidney injury. Okay, so now we've kind of reviewed the definitions and the different types of acute kidney injury that can occur. Who here thinks they're from the smallest, most farthest away from civilization hometown? Who's from, I don't know. I asked this question once and everyone's like, I'm from Stores. Who's from the smallest town? Yeah?
I'm from the smallest town in Connecticut.
Oh yeah? What's that one?
Union, Connecticut. It's right near Sturbridge, like if you go on the highway.
Okay, well, we'll use that. All right, so we have a patient here from Union, Connecticut, who is a healthy adult who got hit by a truck. And because they live in middle of nowhere, Union, Connecticut, they are not able to be helped for a few hours. They're kind of bleeding all over the road, losing some blood before we can get to them to help them. We do get there, however, and the patient is rushed to surgery. They are still suffering some hypotension because they lost all of that blood. And they have to receive many liters of blood products and IV solutions to keep them alive during that surgery. This patient's urine output in the last 24 hours is 250 ml. Let's go ahead and classify this acute kidney injury in as many ways as possible that we just learned. How about, let's look at the urine output first. What kind of kidney injury does this patient have? Oliguric. Beautiful. They're oliguric. They're not making no urine, but the amount of urine is reduced for sure. How about where type of injury? Do you think this is pre-renal, intrinsic, or post-renal acute kidney injury?
Intrinsic?
I heard pre-renal and I heard intrinsic. I would say both of those are right. I would say when he first started bleeding and his blood volume was reduced, that was pre-renal. Since this patient wasn't able to be helped right away and developed a lot of hypotension, probably the tubules got affected too, which would make it intrinsic. So I think he started out pre-renal and ended up intrinsic. What is this patient's prognosis? How about, was it good, medium, poor? 4, yes. And his kidneys are injured so bad that he's not making as much urine before, which is associated with like a 50% survival rate if he ends up needing acute kidney injury, or needing hemodialysis to help with his acute kidney injury. So this would be a sad story, but I made it up. So he did great. He recovered. He returned to Union, Connecticut, where he lived a happy and healthy life. All right. So before we get into drug-induced nephrotoxicity, we still have to talk about what lab values that you can look at to try and figure out if this type of acute kidney injury is pre-renal, intrinsic, or post-renal. And I guess I should mention, not just lab values, please talk to your patient for clues. Did the patient start a new medication? Was the patient home vomiting for the last 3 days? These things will give you clues that are probably even more important than looking at lab values. But there are 2 lab values / tests that you want to look at for every person that comes in with acute kidney injury. And those are the BU1 to serum creatinine ratio and the fractional excretion of sodium, which is pronounced FeNO sometimes as shorthand. And we'll go through those 2 really quick. So the first thing you definitely want to do is look at the patient's BU1 to serum creatinine ratio. Remember last week I mentioned BU1 is affected not only by kidney function but also by volume status. So that's why we end up comparing it to serum creatinine a lot, because serum creatinine is not affected by your fluid status. A normal BU1 to serum creatinine ratio is 10 to 1 to about 15 to 1. In pre-renal failure, the ratio elevates to 20 to 1. This is because, do you remember that BUN likes to follow your body water wherever it goes? So in pre-renal failure, patients don't have enough blood volume going to their kidneys, right? So your body is hanging on to all of the sodium and water that it can to get more blood to the kidneys. Whenever the body hangs on to sodium and water, it hangs on to BUN as well. So in patients with pre-renal failure, both their BUN and serum creatinine might be elevated, but the BUN is going to will be disproportionately high because you're hanging on to all of that volume. Does that make sense? I feel like I mess up BUN every single time. BUN just likes to follow your body water. In pre-renal failure, you don't have enough blood volume, so you're hanging on to all the water that you can, so you're hanging on to all the BUN that you can too. In intrinsic and post-renal AKI, blood volume isn't the issue. Something else has gone wrong. So patients with intrinsic or post-renal AKI will have a normal BUN to creatinine ratio of 10 to 15 to 1. Does that make sense? Let me know if it doesn't help. I'd readdress it after break. The next thing that we look at is your fractional excretion of sodium. And this is actually similar a little bit to the BUN scenario. It helps us identify if someone's in pre-renal failure or if they have some other type of renal failure. So your fractional excretion of sodium is the percentage of sodium that's filtered by the kidneys that comes out in the urine. In pre-renal AKI, you don't have enough blood getting to the kidneys, so your body is hanging on to all of the sodium and water that it can to try and increase that blood volume. So in pre-renal AKI, you're not peeing out a lot of sodium. Your body is compensating by keeping that sodium and water reabsorbed. So in pre-renal AKI, your fractional excretion of sodium in the urine is going to be low, less than 1%. In intrinsic AKI, especially if your tubules are hurt, your kidneys lose the ability to concentrate urine at all. So the amount of sodium that you pee out in intrinsic AKI is just equal to the amount of sodium that's filtered across the glomerulus, because the tubules are not able to do any concentrating or diluting. Because of this, you pee out. It's just plasma water because you're filtering stuff and it's going right out instead of having any tubular involvement. So those patients are going to have a fractional excretion of sodium that is greater than 1%. Here's a look at what the equation looks like. I will provide it for you on the exam, but you need to know how to use it and how to interpret it. Essentially, what the fractional excretion of sodium does is it looks at your urine sodium in proportion to your serum sodium, and then it just happens to compare it to your urine creatinine in proportion to your serum creatinine because creatinine isn't affected by fluid status. So the creatinine is just a comparator, and we're trying to see how much sodium is coming out in your urine. A normal fractional excretion of sodium is 1%, and then less than 1 pre-renal, greater than 1 intrinsic. All right, now here's one more key point. Let's say that you have pre-renal AKI, but you go ahead and give somebody a diuretic, which is probably not a good idea because they already had decreased blood volume, but they're on a diuretic. What do you think is going to happen to the fractional excretion of sodium if you put someone on a diuretic? Go up. It will go up because a diuretic doesn't care if you're dehydrated or not. It's going to say pee, pee, pee. That's my job. I'm here to make you pee. I don't care if you're already dehydrated. So if your patient is on a diuretic, you have to throw the results of their fractional excretion of sodium out of the window because it's going to be high no matter what. It's an important point to make because physicians get excited and say, oh, look, the fractional excretion of sodium was high. Clearly it was pre-renal. And you can pipe up and say, well, the patient was on a diuretic, so this test isn't that useful anymore. So here's just a table to help you guys study. It just pretty much goes through pre-renal, intrinsic, and post-renal types of acute kidney injury. With pre-renal AKI, you have less blood flow to your kidneys, so your body is conserving all of the water that it can. Because of that, your pee is going to be dark yellow, it's going to have a high specific gravity, and you're going to have high BUN to serum creatinine ratio and a low fractional excretion of sodium because you're hanging on to all of that sodium. It's not coming out in your urine. With intrinsic and post-renal, the opposite is true. You're going to have a fractional excretion of sodium greater than 1% and a normal BUN to serum creatinine ratio. So finally, the question I was asking myself as I was coming up with these slides was, why do we care? Why do you care if somebody's in pre-renal versus intrinsic or post-renal AKI? And the issue is, the treatment for your AKI is going to depend on the type of injury. If somebody is pre-renal and they're not getting enough blood to their kidneys, the number one thing you can do for them is give them IV fluids. That's going to increase their blood volume. It's going to increase the amount of blood that gets to the kidneys. On the other hand, if you have intrinsic or post-renal AKI, let's say you're not making a lot of urine. If I go ahead and tank you up with IV fluid, there's nowhere for that fluid to go. It's just going to end up fluid overloading you, making it difficult for you to breathe. It's not a good idea to fluid overload someone who's not able to make urine because they can't get rid of any of that. They end up looking like the Michelin Man. Because of that, for intrinsic and post-renal AKI, you should not start fluids. You should keep them euvolemic, but you have to be very careful not to fluid overload them. All we can do is identify the cause of that AKI, remove it, and watch and wait. So just to finish off the general kind of AKI picture, there's no medication that magically fixes the kidney. If you can discover it, you will become very, very wealthy. We certainly have gone through periods of time where we thought various medications were magically good for the kidney. After a while, we thought that dopamine infusions helped increase blood flow to the kidney. Nothing seems to work. So you researchers out there, make that your mission. The only thing we can do is identify the precipitating factor, which is where pharmacists are very important. And then after removing that factor, keep fluids balanced, avoid any other nephrotoxins, and watch and wait. The kidneys will either get better or they will stay chronically injured. And the only way to figure that out is to wait a month and see what the kidneys decide to do. All right. I think let's take our break here because that'll be a good intro to AKI and then drug-induced nephrotoxins. So go ahead and take 10 minutes, and then we'll get to talk about which drugs do what to the kidney. Of both community and hospital-acquired renal failure, or acute kidney injury, I should say. That's kind of atrocious because anytime we have drug-induced kidney injury, that's something that we as a medical community did to a patient. We prescribed a drug that hurt their kidney. So 1 out of 5 of every people with kidney injury got it from the medical community. In the elderly, drugs are accountable for 2/3 of acute kidney injury. So we're really knocking down our elderly folks with our drug prescribing. So that's why you guys as pharmacists should really focus on preventing this stuff. If you see a physician prescribing a nephrotoxic drug to an older individual, call them up and at least have a conversation about those risks and benefits of starting that medication. So let's ask ourselves real quick why kidneys are so vulnerable to drug toxicity. So without looking at the next slide, what is the common sense answer why the kidneys are so vulnerable? What do you guys think?
responsible for filtering it out?
Yeah, they're filtering all of these drugs. So they're routinely exposed to much higher concentration of the drug than the rest of your body is. It all gets concentrated in those kidneys as it tries to eliminate them. A couple other things to point out besides that main obvious reason is that your kidney needs a lot of blood. Kidneys weigh about 0.4% of your total body mass, but they receive 25% of your rectal cardiac output. Because they see a lot of blood, they see a lot of drugs, and also, if anything interferes with blood flow, the kidneys feel it right away because they need so much of it. The kidneys, as I mentioned, also have a very high metabolic rate. They have a lot of enzymes doing active transporting in the tubules and things like that. So as I mentioned before, if anything stops oxygen flow to your body, the tubules and your kidneys will feel it first. Just like with other types of acute kidney injury, the damage that happens to your kidney can occur in different areas. It can affect the blood vessels, your glomerulus, it can affect the tubules, and it can affect the interstitium, which is again that tissue that surrounds your glomerulus and your tubules to help maintain tonicity. The signs and symptoms of drug-induced nephropathy they're pretty similar to the signs and symptoms that you would see with any type of acute kidney injury. Patients might become fluid overloaded if they stop peeing, or even if they're oliguric, they might have some fluid buildup. They develop lab abnormalities. So you probably learned with Dr. Wheeler that the kidneys are responsible for maintaining your potassium balance. If the kidneys take a hit, your potassium can become quite elevated because nothing is there to remove it. And of course, you'll see your increased waste products like serum creatinine and BUN. The urine is always full of clues about what type of kidney injury has occurred. Crystal urea is always exciting. That's drug crystals in the urine that make pretty patterns when you look at it under a microscope. Proteinuria is protein in the urine, usually signifies damage to the glomerulus. Pyuria is pus in the urine. That's more indicative of a kidney infection like pyelonephritis. Hematuria is blood in the urine. That also tends to be either an infection or an autoimmune disease that's caused some inflammation of the kidney. And polyuria is excessive urination. That can be a sign. We talked about how anuria is definitely a sign of kidney injury, but excessive urination can end up being a sign that your tubules aren't concentrating your urine anymore. So the urine can be full of possibilities. I talked to a nephrologist who says he has more pictures of people's urine on his phone than he has pictures of his kids. He runs into these interesting urine patterns and always has to take a picture. I'll refer to later. So when you're on rounds, if you get a chance to look at someone's urine, go for it. Go take a look under the microscope. It's pretty cool. Prevention of drug-induced nephrotoxicity is, again, just what you would expect. You want to avoid nephrotoxic agents. If you have to use a nephrotoxic agent, you need to talk about the risks and the benefits. Think about alternative agents that might be less harmful to the kidneys. If you do need to prescribe a nephrotoxic agent, make sure it's the lowest effective dose and for the shortest duration of time. And monitor the serum creatinine and BUN while the patient is on that medication. And then, of course, be cautious with fluid imbalances because you don't want to tip somebody into pre-renal AKI by dehydrating them. And you don't want to overload somebody who's not making urine with a bunch of fluids either. So balance is key. So for the rest of the lecture, I'm going to spend a little bit of time going through each of these 6 types of drug-induced nephrotoxicity. They all have to do with different parts of the kidney that get affected. So the first type of acute kidney injury that we're going to talk about is called pseudorenal failure. And it's called pseudorenal failure because it's not actually renal failure at all. The reason it looks like the patient might have renal failure is they'll have elevated either serum creatinine or BUN. but in reality, their GFR hasn't changed. Some examples of drugs that cause pseudo-renal failure include corticosteroids and tetracycline. Both of those medications will increase protein catabolism, so you'll see an elevated BUN happen. The BUN will go very high. The team will get worried about renal failure. You can jump in and say, no, it just appears that way. The drugs trimethoprim, which is the component of Bactrim, and cimetidine, the H2RA, inhibit that secretion of creatinine in the tubules. Remember that creatinine is mostly filtered at the glomerulus, but there's a little bit of secretion. When that secretion is inhibited, your serum creatinine will increase, but your GFR is going to stay the same. I always mention Bactrim because it's like a daily fight on rounds at Helen Haven Hospital. We start somebody on Bactrim, their serum creatinine goes up. The residents say, oh my God, we've given them renal failure. And I say, why don't we switch to a different antibiotic? And I bet you'll see that creatinine come right back down. Because it's the secretion of the creatinine that's been blocked, not the GFR that's going through change. The other case of pseudorenal failure that I saw once was we had a young guy in his 20s. He's a pretty skinny, healthy-looking guy, but on 2 separate occasions, when he came in to get just his normal physical, his creatinine levels came back really high, like at 2.5, which is crazy for a young guy. He would get sent straight to the emergency department to be evaluated about why his kidneys had failed. And as soon as he was admitted to the hospital for further testing, his creatinine would come right back down, just in a day or 2. It wasn't until the second time that this happened that we got around to asking about various supplements that were not on his medication list. It turns out that he was, being really skinny, he had been trying to bulk up. He had been taking huge amounts of the substance creatine, which you can buy at any health food store. And so when he was taking, and this was not like a regular dose. I forget how many cupfuls he was doing, but he was kind of trying to replace exercise with creatine supplementation. And so as soon as he would get admitted to the hospital, he would be away from his creatine, and the serum creatinine would come right back down. So that's another case of sort of self-induced pseudo-renal failure that I've seen. So always be sure to question your patients about not just their med list, but if they're doing anything, and you can't say, are you doing anything odd, but ask them about their supplement use. The next type of AKI, oh yes, go ahead.
I was just wondering, so that's okay to have, like you don't have to really do anything, there's nothing wrong with having pseudorenal failure?
There's nothing wrong with it. I would say there is something wrong with taking huge amounts of creatine, so I think we backed him off just in case. You never know, like, at such high levels what might happen. But yeah, no, there's absolutely nothing wrong. So if you start someone on Bactrim and their serum creatinine bumps up a little bit and everyone says, we expected that, you can continue with therapy and nothing bad will happen. The next type of AKI is the one that, unfortunately, I have to spend the most time on just because it's more complicated. But it's called hemodynamically mediated renal failure. It's just another way of saying pre-renal. Hemodynamics is your blood flow. So it's just another way of saying that a drug alters the blood flow to your kidneys. So just like with any pre-renal failure, there's decreased blood flow to the glomeruli, which causes a decrease in intraglomerular pressure, a decrease in GFR, but no actual kidney damage. The risk factors for getting this type of pre-renal failure is just like I talked about before. It's people who already don't have a lot of blood going to their kidneys. People with CHF, people who are dehydrated and so have low blood volume, patients with low protein in their blood where fluid has left their blood vessels. These are the kind of people that get hemodynamically mediated renal failure. And the agents that we're going to spend time talking about are diuretics, ACE inhibitors, and NSAIDs. Now, diuretics are really straightforward. We over-diuresed you, so now you're dehydrated. You don't have enough blood volume to get to your kidneys. So sometimes it's just a matter of somebody was put on diuretics, not monitored appropriately, and now they're dehydrated. ACE inhibitors and NSAIDs are a little bit more complicated. The three mechanisms that we're about to review are, again, diuretics decrease your total blood flow. You just have less blood volume to work with. NSAIDs cause vasoconstriction of your glomerular afferent arteriole, which will decrease your intraglomerular pressure. And ACE inhibitors cause vasodilation of your glomerular efferent arteriole. It's actually pronounced efferent, but I'm going to say efferent because I feel like afferent and efferent are too close. So I'm going to say your efferent arteriole goes through vasodilation. And we're going to talk about those two in depth because for me, as a student, that wasn't intuitive what happens with these. So in order to show you guys some animations that I made, I have to orient you to the kidney that I've tried to very grotesquely draw. So here's a picture of a glomerulus. As you remember, it's just this ball of capillaries, right? It's like this amazing filter that does so much for your body, and it's really just a ball of capillaries. Let's say this is the afferent arteriole going in, and your efferent arteriole where blood leaves from. Let's say you grab your afferent and your efferent arteriole and go like this, and then put it on a paper. That's what this is going to look like. We've got this actually, I copied a little bit from Dupiro, so you can blame Dupiro for this very simplistic way of looking at it. But here we've got afferent arteriole supplying blood. This is going to be our glomerulus, this circle here. And then anything that comes out here is to symbolize your GFR, and the efferent arteriole is over here, symbolizing blood leaving the glomerulus. So that'll come up again when we talk about NSAIDs and ACE inhibitors in a couple slides. So just as a review, NSAIDs cause acute kidney injury because of constriction of the afferent arteriole. Remember that NSAIDs work by blocking those cyclooxygenase enzymes 1 and 2. By blocking that, they're decreasing the production of prostaglandins. Prostaglandins are inflammatory mediators, so it's good that they're being blocked, but prostaglandins in the kidneys are responsible for keeping your afferent arteriole nice and open. So if you take out the kidney's prostaglandins, instead of having a nice open afferent arteriole, you're going to get some constriction. Renal failure will occur within days of starting therapy with NSAIDs, and usually it's reversible. If we got the patient, like Fred in our case conference, we got him on some around-the-clock Tylenol, and hopefully his serum creatinine came back down. Your at-risk patients for AKI from NSAIDs are patients with baseline CKD, then of course anyone with decreased blood flow to their kidneys. So you got your heart failure, your over-diuresed patients, and your patients with cirrhosis that have ascites and low blood protein. These guys all have low blood flow to their kidneys. Finally, the elderly seem to be at risk as well. All right, everybody ready to look at the slides because I'm going to try and do a little animation here. All right, I'm going to try and show you how NSAIDs can cause a constricted afferent arteriole. So let's say that you're walking in the woods and you meet a bear, or let's say you're taking an exam. Either way, your sympathetic nervous system is usually activated in preparation to run from that bear, and run from the exam again. So your body will release a whole bunch of sympathetic system mediators, including norepinephrine, endothelin, vasopressin, and angiotensin II. You can really focus on norepinephrine when you think about this stuff. What your sympathetic nervous system is designed to do is to increase your heart rate, increase your heart's contractility, and increase your blood pressure by constricting all of your blood vessels. This way, you're going to be ready to run away from the bear. One thing that these substances do, though, is they constrict all of the vessels in your body, not just your coronary vessels. So your afferent arteriole gets constricted, and your GFR decreases. Ready? Here we go. So now usually, the reason you guys don't go into renal failure every time you take an exam is that your body produces vasodilating prostaglandins, which, if you watch, are going to vasodilate that afferent arteriole so that you can maintain your intraglomerular pressure and your GFR is going to stay the same. Now let's take a look at a patient who, let's say they have CHF. So their sympathetic nervous system is activated all the time, not because they're running from a bear, but because they need their sympathetic nervous system to be activated to increase their heart contractility so that they're still getting blood flow to all their organs. These patients live in a perpetual state of having a constricted afferent arteriole. So they always have norepinephrine present, and their afferent arteriole always looks like that. Somewhat. Now, for most of these patients, they still have renal prostaglandins that are going to be released and help maintain their intraglomerular pressure. But if they take NSAIDs, there's no renal prostaglandin release, and so their afferent arteriole is stuck in the constricted position. That's why if you're on a cardiac rotation at the hospital and your patient kind of admits to you that they're taking NSAIDs, it's not something that you say, oh, okay. Like, you need to immediately counsel them about why this isn't helpful. Same with liver patients. We always think that, they should avoid Tylenol, but really, they need to avoid NSAIDs because they also rely on their sympathetic nervous system to get blood flow throughout their body, and so they have these constricted afferent arterioles. All right, does that make sense, the NSAID standpoint? You get rid of those vasodilatory prostaglandins, so you're stuck with a constricted afferent arteriole and a decreased GFR. All right, now let's do ACE inhibitors and ARBs. ACE inhibitors and ARBs can cause acute kidney injury by causing vasodilation of the efferent arteriole. And the people that end up getting AKI from ACE inhibitors are the people that have a lot of angiotensin II in their system that is helping them maintain their GFR. Once you start an ACE inhibitor, your serum creatinine will rise up to 30% within 2 to 5 days of initiation. That's not a bad thing. It's something that we expect. It's just, to us, we say, oh wow, that ACE inhibitor is working. And we expect the serum creatinine to stabilize within 2 to 3 weeks. If it goes above a 30% increase, then we have to start wondering about either reducing the dose, making sure that patient is well hydrated, or something like that. The renal failure is reversible upon stopping that ACE inhibitor. All right, so here's my animation to try and show you why vasodilation of the glomerular efferent arteriole will not be good. All right, so think about, let's do congestive heart failure again. You have your CHF patient whose heart pump isn't working well, so they're not getting as much blood to the kidney as usual. What does your kidney do in response to low blood volume? Do you guys remember?
Perfusion.
What?
Hyperfusion.
That's right.
They want to maintain perfusion. What system that's activated? There's a system. RAS. Very good, right? Cardio. I know it's out of your minds now, but your renin angiotensin II aldosterone system is activated during times of low blood flow. And one of the things that angiotensin II does do is constrict, as I point at the screen, is constrict that efferent arteriole to help maintain glomerular pressure. So here we go. We're going to constrict. We're going to release angiotensin II. It's going to constrict that efferent arteriole, and it's going to maintain the GFR in patients who have difficulty maintaining it, like CHF patients. When we go ahead and start an ACE inhibitor, angiotensin II is blocked, and so the efferent arteriole will vasodilate, and these patients will continue to have a decreased intraglomerular pressure. So ACE inhibitors cause AKI in patients that needed angiotensin II to constrict that efferent arteriole in order to maintain their GFR. It undoes that, so you have vasodilation of the efferent arteriole and your GFR is decreased. Does that make sense? The Friday after we get back from break, I have CPPS, and I will bring you a little demonstration of this concept as well. So the patients that are at risk for developing AKI from ACE inhibitors are those who depend on angiotensin II to maintain their GFR. So that's your usual suspects. It's your patients with congestive heart failure, your dehydrated patients, your patients with ascites. Nephrotic syndrome is where you pee out large amounts of protein, so you have very low protein levels in your blood. All these patients who have decreased blood flow to their kidneys are going to get some degree of serum creatinine elevation from ACE inhibitors. The last patient population that I wanted to point out to you is also patients with bilateral renal artery stenosis should not be started on ACE inhibitors. Here's a picture of bilateral, well, this is one of the renal arteries that's stenosed. I am not a pro at reading CT scans, but this thickened area right here in the renal artery is a stenosis or a thickening. A renal artery stenosis means you have really thick renal arteries. If you have thickening on both sides of your renal arteries, we're so worried that we think you're so reliant on angiotensin II to maintain your GFR that we're worried that if we start an ACE inhibitor, we're going to tip you over into end-stage renal disease. So that's why we want to not start an ACE inhibitor in people with this very one specific condition, narrowing of the two renal arteries. If you do, so as you guys know from cardio, we want to start all kinds of people on ACE inhibitors. So a lot of times we do go ahead and start ACE inhibitors in patients who are at risk, but we want to make sure that they're well hydrated when you do so. You want to start with a really small dose of ACE inhibitor. You can even start out with a short-acting ACE inhibitor. Captopril has to be dosed 3 times a day, which is really annoying, but if you had somebody develop low blood pressure or AKI, it would be out of your system that much faster. Don't let anyone get sent home on Captopril, though. That drives me crazy. Patients who are starting on ACE inhibitors might take a break from being on diuretics to make sure they're well treated or well hydrated. And we really don't want anyone to be on NSAIDs when you're starting ACE inhibitor therapy. In fact, in Australia, they call the combination of diuretics, ACE inhibitors, and NSAIDs the triple whammy because they did research on their population and found that it was like 90% of their patients that came in with AKI were on that combination of 3 drugs. So they turned it into a public awareness campaign to not do the triple whammy to yourselves. You might argue, based off of cardio, that a patient really needs, that certain patients, CHF patients, really need ACE inhibitors and probably need some diuretics. So just make sure they stay off of the NSAIDs so we don't get that triple whammy. So this question is actually in here to just prove a point, but to go ahead and ask you guys, which of the following patients should not be started on an ACE inhibitor? Is it the hypertensive patient with end-stage renal disease, the hypertensive diabetic patient with stable CKD, a hypertensive patient with CHF, or the hypertensive patient with bilateral renal artery stenosis? A, B, C, or D. So I know the question itself is really, I just told you that, but I threw it in there because all of these other choices, A, B, and C, these patients need to be on ACE inhibitors. So I actually want you guys to go out and be ACE inhibitor advocates and not be scared of the AKI that ACE inhibitors can cause. So for example, patient B is often not on an ACE inhibitor because they're like, well, their serum creatinine is already 2. I don't want to cause AKI and make their kidneys worse. But what we'll talk about with CKD is ACE inhibitors actually prevent the decline of renal function over time. So even if the patient has CKD, as long as it's a stable CKD, you should go ahead and encourage people to start ACE inhibitors because they're good in the long run. Yes, they're going to increase your serum creatinine by up to 30%, but in the long run, we'll talk about how ACE inhibitors are nephroprotective. So my story about prerenal AKI comes from when I was a PGY1 resident. We admitted a 92-year-old, kind of frail, grandma-type lady to the general medicine floor. She had been recently diagnosed with congestive heart failure, so they had started her on diuretics, ACE inhibitors, a beta blocker. They started her on a whole bunch of meds. She had gone home from the hospital and not felt very well, so she stopped eating and drinking, but kept taking her diuretics and her ACE inhibitors. And so when she was admitted to the hospital, her serum creatinine was all the way up to 0.4. Remember what I taught you guys with uremia, the waste products can cross your blood-brain barrier? She was swearing up a storm, saying words that her family didn't even know she knew. She was, threatening to pee in the bed on purpose. Like, she was just embarrassing her poor family. They were like, we swear she's like the nicest lady. But it was because of these elevated waste products that had crossed through her brain. So we admitted her. We discontinued the ACE inhibitor and diuretics temporarily so that she could get well hydrated again. So the next day, her serum creatinine was 3. The next day after that, it was 2. And by the 4th day, her serum creatinine was all the way back down to 1. And at that point, she actually got out of bed and did a little jig, trying to convince the doctors that she was ready to go home. So clearly, we had eliminated a lot of these waste products and she was back to her old self. So we did end up, I think we made her wait one more day, which really hacked her off. But we did end up restarting the diuretics and the ACE inhibitors, but at a later date, making sure that her kidney function was very stable and that she was very well hydrated at that time. Here's a slide just to help you study when you're thinking about this sort of complicated issue of afferent and efferent arterioles. Remember that the patients who are at risk are your congestive heart failure, your volume depleted patients. Usually, prostaglandins and angiotensin II help maintain your GFR by causing afferent vasodilation and efferent vasoconstriction. But if you start a patient on an NSAID, you're going to get rid of this ability. And if you start a patient on ACE inhibitor, you're going to get rid of the efferent vasoconstriction ability. So this is just a summary to help you take a look at this when you're studying. Whew, prerenal. That's the hardest one to explain. You guys ready to move on? Any questions? All right, so we've done pseudo, and we've done prerenal. We got 4 more types to go. Glomerulonephritis is the next one, and as you guys can all guess, the glomerulus is affected. It has an itis, or inflammation. Usually, we see glomerulonephritis as more of an immune-mediated issue that happens. Your body will see a drug as an enemy and attack it, and it might harm the glomerulus in the process. There are some drugs that also have direct toxicity as well. As we talked about last week, the main hallmark of glomerular damage is that you'll see protein in the urine. So I stole this figure from last week, from myself, I guess. If you're looking in the capillaries, so pretend you are a red blood cell traveling along this capillary here. In a normal glomerular capillary, proteins and red blood cells just continue along and don't make it into the urine. If something comes along and damages the basement membrane and epithelial cells, that's when you start seeing protein leak into the urine. Usually, your body wants to hang on to all proteins. It's like the building blocks of life. You need those things. So it's not until there's glomerular damage that you start seeing that leak into the urine. Really severe glomerulonephritis is called nephrotic syndrome. Nephrotic syndrome happens to either really young kids or actually older adults above 80 years of age. Nephrotic syndrome occurs when your glomerulus is so damaged that you start peeing out a lot of protein. So these patients have very low protein levels in their blood and very high protein levels in their urine. As a result, we get a lot of third spacing as water looks to go from areas of low concentration to high concentration. So because of the low albumin levels in your blood, water leaves your blood vessels and accumulates in other places. So you can get swelling of your ankles, and as this little boy is demonstrating, you can get swelling of the area under your eyes as water leaves your vessels and accumulates in other places. Now my grandpa actually was one of the people who was above 80 years old and developed nephrotic syndrome. And when he saw a dietitian to talk about this, the dietitian told him to eat 10 eggs a day. Apparently the egg whites of hard-boiled eggs are almost pure albumin protein. So he was someone who's always watched his diet, so he was really kind of annoyed to have to eat 10 eggs a day. We were trying to get him excited about it, like, Grandpa, you have like an omelet and casserole, like you can go crazy. But I mean, it's the only time in the world where you're like, well, it's good for me, I have to eat all these eggs. So he actually did end up recovering from this nephrotic syndrome. It is something that you can get better from, but you do have to, it's very interesting from a diet perspective while you're working on that. So some examples of drugs that can cause glomerulonephritis include NSAIDs. You can see NSAIDs are just, I don't know, I love to hate them, they come up a lot. The way that NSAIDs cause glomerulonephritis is that the body sees the NSAID as a threat, and it releases lymphokines that actually end up attacking the podocytes of the kidney. Chronic heroin abusers also have glomerulonephritis. This seems to be more of a direct toxicity. It comes into contact with the glomerulus and causes inflammation and fibrosis at that point. And then finally, parenteral gold, which is a drug used to treat rheumatoid arthritis. It used to be first line, so we've come up with better solutions now, but it's still used occasionally as a last line agent. And with parenteral gold, the body perceives it as an antigen, and the antigen-antibody complexes build up and cause glomerular damage. And I have a picture of that on the next slide to help illustrate how that happens. And glomerulonephritis is usually reversible. Of course, with our chronic heroin abusers, they might very well end up with end-stage kidney disease, not being able to stop the offending agent. So here's a look at how parenteral gold could damage your glomerulus. So we blew up, here's our glomerular capillary, and we blew up a picture of the glomerular wall here. The parenteral gold goes in and accumulates all around the basement membrane here. Your body sends antibodies to attack the gold, and these immune complexes end up damaging the epithelium of the glomerulus so that proteins are able to leak out. I would never have understood this had I not come across this picture, but I think it really is helpful to see those immune complexes building up and damaging that glomerular capillary. All right, so that was glomerular damage. Got 3 more to go now. Ready? Now we're going to talk about tubular damage, acute tubular necrosis. So this is a direct type of damage that happens to the tubules, and it usually is caused by renally eliminated drugs because they get so concentrated and when they come into contact with those tubules. It can be in part dose-related. And the other way that the tubules get harmed is if the drug causes any type of ischemia, because again, those tubules need so much oxygen to do what they do. The tubule cells literally die and slough off and come out in your urine. So one of the key points to think about when you're studying acute tubular necrosis is that you will see what are called casts in the patient's urine. Casts are just cellular debris that have had to travel through the rest of the tubules. So they tend to be shaped just like the tubules are. So if you ever get a chance to look at someone's urine under a microscope, if there's all these little tubule-shaped, elongated casts, that could be acute tubular necrosis. Some examples of drugs that can cause ATN, or acute tubular necrosis, include the antibiotic class aminoglycosides, contrast dye, which is used in CT scans to make images more clear, and the antifungal agent amphotericin. When I was a student, I was taught that amphotericin is amphoterrible for the kidneys. So if that helps, put it on. ATN can be reversible if it's identified early. However, my fellowship preceptor every now and then gets asked to be an expert witness in trials where patients were on long courses of aminoglycosides and ended up with permanently damaged kidneys needing to be on dialysis. So it does happen if you don't monitor aminoglycoside medications. So I'm going to spend a little bit of time on two different types of ATN. We're going to talk about aminoglycosides, and then we're going to talk about contrast dye. So just to refresh your memory, I know you haven't had ID yet, right? Sorry.
Yes.
Next semester. So examples of aminoglycoside medications that would be useful to be familiar with are gentamicin, tobramycin, and amikacin. Aminoglycosides are famously nephrotoxic, one of their main side effects. Remember that, because then you'll wow Mueller when you take ID. And we think that the nephrotoxicity that occurs is from accumulation of the aminoglycoside in the renal tubule cells. So as you can imagine, this isn't a type of renal failure that happens right away. It happens with longer courses of therapy so that the aminoglycoside starts to accumulate in the kidney. It's usually preventable if identified early, but again, every now and then, you might be asked to testify as an expert witness and say, yes, that was not a good idea to give them that long course and not monitor anything. So you do want to identify this quickly and stop it so that you can reverse the AKI. Risk factors for developing aminoglycoside-induced ATN include being on any other nephrotoxic drugs, so cyclosporine, amphotericin B, vancomycin, diuretics. These things will all increase your risks of getting ATN. And then this is an important part to focus for. We try to minimize aminoglycoside nephrotoxicity through dosing. We don't want to allow aminoglycosides to accumulate. So if we give doses less frequently to patients who are at risk, then we'll be less likely to get high trough concentrations. Does that make sense? So be careful not to dose too often. That's where you'll see accumulation occur over time. All right. So now we can move on to contrast-induced acute tubular necrosis. Just as a reminder, IV contrast dye is something that's administered to patients so that when they undergo a CT scan, it lights up really nice and it can help you diagnose issues that you couldn't see without the contrast dye. So I just put in some cool CT scans that use IV contrast dye. In this one, this is an abdominal CT, so this is the patient's spine. And over here, these are the kidneys. And then the hand one I just thought was pretty cool. So you can see every single vein after you've given somebody IV contrast dye. So the reason we're spending time talking about contrast, which it is a drug for sure, but you don't always think about this drug a lot as pharmacists. But the reason we're spending time on it is that it's the third leading cause of hospital-acquired acute renal failure. And there's really no way in today's society that we're going to stop doing CT scans on people with IV contrast dye. So again, those of you guys who want to be researchers, figure out how to prevent contrast-induced nephropathy, and you will be very rich and help humanity greatly. There is a specific type of patient that gets ATN from contrast dye, and that is a diabetic patient who has pre-existing renal insufficiency. That's a really big key point to put a star by it. Most patients, like if I were to scan most of you guys, you would not get AKI. But if you have diabetes with some pre-existing renal impairment, 40 to 50% of the time, half the time, you're going to get AKI if you undergo a scan that uses IV contrast dye. So we know our population very well. And of course, contrast-induced nephropathy is such a big deal because it increases morbidity, mortality, and healthcare costs. There's two ways that we think contrast dye might cause ATN. The first is we think that maybe the contrast triggers really potent vasoconstriction, which would cut off oxygen to the kidneys and hurt the tubules that way. The other way that's been proposed is that maybe contrast causes a lot of oxidative stress, and that causes the damage that way. Nobody really knows, or else we probably would have solved this problem by now. The things that we've learned to do to prevent contrast-induced nephropathy are, one, of course, get rid of all nephrotoxic agents. Some centers consider administering N-acetylcysteine, which is an amino acid derivative. What have you guys learned N-acetylcysteine is for? Yeah, Tylenol toxicity. You also might know it smells like rotten eggs if you've ever had to prepare it. It's really not lovely. Anyway, the thought is that if you that N-acetylcysteine is a very potent antioxidant, and so maybe it helps prevent oxidative stress. Some studies have said yes, some studies have said no. Some people said, well, I don't care if it smells like rotten eggs, let's give it to them anyway in case it helps. Hard to say. The only intervention that has real evidence behind it for preventing contrast-induced nephropathy is hydration. You must give these patients hydration with IV fluid. It's unclear what type of IV fluid is best. There's a debate about sodium chloride versus sodium bicarb in these patients. But as long as you get IV hydration right, regardless of what solution you use, you should be able to prevent some of this acute kidney injury. I'm just going to spend a couple of slides talking about this controversy about using sodium chloride versus sodium bicarb, because I think it's something that you're going to have to advise physicians about in the future. So there's a theory that sodium bicarb is better because it alkalinizes your tubular fluid and your urine, and there's some thought that oxidative stress likes to occur in acidic environments. So that by alkalinizing stuff will prevent this oxidative stress. And animal models have suggested that this is true. But nobody's had great luck finding the same thing to be true in human clinical trials. So this is a forest plot of odds ratios of different trials. So just to orient you to a forest plot, remember that if the confidence interval crosses this line of 1, then the results were not significant. If the finding is on this side of the chart, it favors bicarb. If it's on this side of the chart, it favors normal saline. So you can see that a couple of trials have said that bicarb is helpful, but most of the trials have really long confidence intervals that cross 1, and so nobody's been really able to show great benefits of sodium bicarb for preventing contrast-induced nephropathy. This slide is it's mostly just for fun. You don't have to study it too much, but let me just show you how our thoughts about sodium bicarb have changed with time. So the authors of this trial did a meta-analysis of all the studies that had been published comparing bicarb and sodium chloride in 2004. And then they redid the meta-analysis every year, including more data that had come out, because this was a really hot topic to study in about 2007. As more and more data came out, it became more clear that sodium bicarb helps a little bit, But look, from 2004, we thought it helped a whole ton. And the more data we add, the closer and closer we're getting to 1. So right now, we think sodium bicarb might help a little bit, but it's not. The results aren't super convincing, and we haven't seen a decrease in the number of patients needing dialysis or the number of patients passing away. So many hospitals say, well, what's the harm? Let's hydrate with sodium bicarb. At Yale New Haven Hospital, sodium bicarb is on shortage and has been for a long time. So we say, you know what? The benefits aren't clear. Well, you have to use sodium chloride. We put our foot down. It upsets people sometimes. So always stay tuned. Maybe we will someday prove that sodium bicarb is beneficial. But right now we think it's beneficial potentially, but not hugely beneficial. All right, we're coming down the home stretch. We've got interstitial nephritis, and then we've got the crystals that can obstruct post-renally. So let's do interstitial nephritis real quick. Remember that the interstitium is that tissue that surrounds your glomerulus and your tubules, and it can get inflamed almost like an allergic reaction. So if you want to, when you're studying, remember that this is acute allergic interstitial nephritis, almost like it's an allergic reaction of your kidney. This is immune-mediated. It's idiosyncratic, which means it happens to some people and we don't know why. We can't predict who it's going to happen to. And it doesn't appear to be dose-related. It's just this allergic response from the kidney. The clinical presentation of acute allergic interstitial nephritis will be important to know because if a patient presents with the symptoms that I'm about to describe, then it'll point you towards this type of acute kidney injury. The classic triad of symptoms include fever, rash, and joint pain. So if someone comes in and they're an AKI and they're also feverish, they have a rash and joint pain, you're really going to start thinking about acute allergic interstitial nephritis. This usually occurs after about 2 weeks of therapy with a drug, because remember the body kind of has to build up antibodies to the drug and then it will attack. So it's usually with longer courses of medication. Although if you're going to re-expose a patient and they already have the antibodies on board, it can come that much more quickly. The third thing to know is that eosinophils are very common in this type of acute allergic interstitial nephritis. Remember that eosinophils are the part of your immune system that is activated during allergic reactions, and so it won't be uncommon to see eosinophils in your blood and eosinophils in your urine if you've had this type of AKI. This here is a kidney biopsy where they literally took a sample of the patient's kidney and put it on a slide so that they could solve what type of AKI this patient had once and for all. And if you see, actually this thing here is the glomerulus. Thought that was pretty cool. And if you blow up a portion of this slide, the red things here that the arrows are pointing to are eosinophils. So this patient had a biopsy and it showed they had acute allergic interstitial nephritis. There's no specific at-risk patients because this is an idiosyncratic reaction and we don't know who it's going to happen to. Occasionally, if you have somebody with a bunch of true drug allergies, maybe you would consider them to be at higher risk, but we really don't know. And it seems that older patients tend to be, they don't get it more commonly, but when they do get it, it tends to be more severe. Some examples of drugs. When you're studying the examples of drugs that can cause acute allergic interstitial nephritis, think about drugs that cause allergic reactions in general. So it's a lot of antibiotics, because that seems to be the big causer of allergic reactions in our population. So penicillins, cephalosporins, sulfonamides, fluoroquinolones. If you see an antibiotic, it's probably going to increase your risk of having this. NSAIDs have also been shown to cause acute interstitial nephritis. I tell you, they do everything. But it tends to be a little bit less severe than antibiotics. Acute allergic interstitial nephritis is usually reversible once you identify and stop the drug. Some nephrologists will go ahead and prescribe a course of prednisone, This isn't necessarily standard of care, but if you have someone with a really severe reaction, you might try it to see if it will speed your rate of recovery. All right, we're on the last one. This is the cool one because there's crystals involved. So the last one is a type of post-renal failure called obstructive nephropathy. And really any structure after the glomerulus can get clogged and cause this type of acute kidney injury. We have physical obstructions due to crystallizations of drugs and tubules, and also tissue degradation products can get stuck in there as well. The common presentation of obstructive nephropathy is a really high rise in serum creatinine and really bad back or flank pain. All of that pressure that the obstruction is putting on the kidney can be quite painful. So here's some pictures of what some patients' urine might look like. Indinavir is an antiretroviral medication in the treatment of HIV, and it has different formations of crystals if you get really excited about crystals. So you can have kind of the standard formation, and you can even have, it's almost like a flower type formation of these crystals. Sulfa drugs can also crystallize, but one caveat that I wanted to point out to you guys, so at normal doses, like a UTI dose of Bactrim, is not going to give you drug crystallization. We see the crystallizations when we're using very large doses of Bactrim to treat like invasive fungal pneumonias. So it's not going to be at a typical dose. I had a student last year who was working at CVS, and the patient came in and said, I'm having kidney problems. Should I be on this Bactrim? And he said, it causes crystals in the urine. You shouldn't be on it. I said, probably would have been fine because it was such a low dose for UTI, not this invasive antifungal agent. So don't go out seeing everyone off of their Bactrim because of the crystals. Think about people who are on big doses of it. So when studying, just remember your sulfonamides and some of the antiretrovirals can cause these crystals. It's usually reversible, and we can prevent it through, if we hydrate the patient really well, that should kind of flush out the tubules so that stuff doesn't get stuck. We can even play around with making the tubules more acidic or more basic if we want to kind of dissolve some of these crystal clumps. So it's definitely something we can work with, and hydration is key. Actually, my fellowship preceptor, he had an old lady who we were trying to keep her hydrated. We were giving her IV fluids, and she still wasn't taking in enough fluids to flush those acyclovir crystals out of her kidneys. So he went to the cafeteria and got her a bag of chips and a pickle. And she had such a big sodium load that she was really thirsty and drank a lot more water than usual, and that helped finish out the flushing of those kidneys. The last way that somebody can get this obstructive nephropathy is if you have tissue degradation products that end up clogging the tubules or the ureters. So for example, if you had really bad acute tubular necrosis and all your tubular cells died and traveled through your urine, all those casts could collect and obstruct your tubules. I mentioned tumor lysis syndrome earlier. That's if the tumor breaks open and releases a whole bunch of uric acid that can crystallize and get stuck. Patients with rhabdomyolysis, myoglobin is very toxic and it can clump together and get stuck. So just think about things that are going to obstruct your tubules, causing KCI. So for your studying pleasure, think about the different areas of the kidney that are affected, and kind of match up what type of injury occurred. And I think we'll go over the questions after the break as a way to refresh AKI in your memory and keep you sort of constantly studying. So we'll save those for another day. And I guess, oh my gosh, have a good Thanksgiving. And I'll see you after the break. Oh, did everyone see? I posted some practice questions on HuskCCT. I would recommend that you take those too.